Well, thanks everyone for joining us today on the webinar. As you see from the title, we're focused on data. Data everywhere, but what to do next? And that seems to be one of the key questions for employers these days, is recognizing they have data, they need data, but not being quite sure what to do next. So today we have a webinar focused on those issues. I'm Tom Perry, President of IBI. I'll kind of lead things off and give some context. Donna Cornwell of O'Neill Industries will talk about her experience in working with data to make decisions. And then John Riddell will finish up talking about a couple of the other employer cases that we studied. John was our co-author here at IBI in our latest research on this issue. So I want to thank you for participating and hope you get a lot out of today. So let's start with what we see as the new employer realities. And I think one of the most important is the C-suite, the CFOs in particular, are playing a different role. The days are gone when the cost of benefits is the cost of doing business. It's all about value. CFOs are asking their colleagues to demonstrate the value of the investments that we're making in health and related benefits. So the conversation is changing for employers. And one of the reasons it's changing is because of healthcare reform. As employers have the opportunity to exit the system, the question of what does health really mean to our business, how important is health of our workforce and our business, those questions are emerging as being key for employers today. What we find is a growing number of employers realize that trying to manage claims costs in separate program silos, group health in one area, disability in another area, workers' comp in a third area, is really a dead end. You can't manage costs managing claims. So employers are looking for new strategies. How do I start to really focus on the health of my working population, and what do I do, and how do I know if I'm making a difference? What does it mean to my business? And they tell us this, and at the same time they say, oh, by the way, I have limited data, limited time, and limited money. So how do I approach this pragmatically? And that's what we're going to talk about today. But let's really set the groundwork for what's at risk for employers. Why should employers really look at health as something more than simply medical costs? And one of the models that we build at IBI, we call it the full cost estimator, is a model that allows us to help employers quantify and estimate the total cost of health. And so I want to give you an example of that before we begin with Donna and John. And we'll use, as an example, a 10,000 life manufacturing company, 70% male employees. 25% of these employees are over 55 years of age, and a little more than 62% in skilled and semi-skilled labor positions. So let's look at what health really means to a company like this. Now let's start that discussion with what we might call the traditional view of health. That is, what health is just medical costs. And for this employer, when we look both at medical costs for employees and for family members, the total cost of medical care on a claims cost basis, annual claims cost basis, is about $24 million. And for the most part, that's where a lot of employers have stopped the conversation in the past. But let's extend that into these other areas. And let's extend it by simply first adding pharmacy costs. So now we see our total cost of health jumping up to nearly $29 million when we look at employees and family coverage. But then let's step outside the healthcare box, the healthcare silo, and start to look at some of the other dimensions of health, some of the outcomes of health that the employer is particularly interested in. And one of the important things to always remember is where the employer can often shift the cost of health care outside the organization by purchasing insurance or whatever, the employer can never shift the cost of lost work time and productivity outside their organization. So let's bring those pieces into the conversation. And let's start with time loss pay. That is, most employers pay their employees when they're missing work for reasons of health, sick leave, disability, workers' comp disability. Those things often are paid by the employer, typically not at 100%, but some benefits are paid at 100% when missing work. So let's add that to the equation, and now we see our total costs of health have jumped up to almost $39 million. And then let's add the productivity piece. The productivity piece as an outcome of health in two components. One in yellow, the lost productivity around absent employees, and the other in green, the lost productivity around reduced performance of employees because of their health. A lot of our work at IBI, we won't go into a lot of that detail today. If you want more information on that, you can always get it through our website or through our staff. But when we add these additional costs of health, now we see the total cost of health care jumping up to $58 million. Not $24 million that we started with, but more than double that cost. And that's really what's at risk for employers. When we look at those numbers in a pie chart, we see that medical care, including pharmacy, is less than half of the cost of health. And those are the numbers that really help employers think about what's this mean to our company and what are the opportunities to improve health and get better outcomes on the backside. But the issue today is data. And I think one of the challenges that employers have is not we have no data, is that we often have too much data. We're being inundated by data. And now with mobile applications and new technologies, we have more data out there than we ever can begin to understand or know what to do with. And so we find that helping employers think about how do I approach data? How do I approach basic measurement? What kind of framework can I put in place that helps me understand the broad issues of health in my population, but does so, at least to begin with, in a pragmatic way? And last April, Bruce Sherman and I, and Bruce is the consulting medical director at Walmart, wrote an article that was published in Population Health Management magazine, which really takes this issue on. That is, what are the key dimensions of health? And how can I start to really bring this together in a pragmatic way? And that's what we're going to talk about today, what Donna will talk about and what John will talk about. So what we say in this article is we assert that there are really, and we think about this as a dashboard. Think about this as information that can fit on one page that you might like to talk to your CFO about. We assert in this paper that there are really 10 key dimensions of population health. Certainly financial or cost. Every employer is concerned about cost. Secondly, program participation. To what degree are employees participating in the health programs that are available to them? Third, biometric screening. What proportion of employees are getting their biometric screenings, and what does that tell you about their health? Fourth, health risks. What kinds of health risks exist in the population and how many? Fifth, utilization of services. Where is medical care delivered and in what amounts? Preventive care. Are employees getting the preventive care that they should be getting based on age and gender? What kinds of chronic conditions exist in that workforce and in what prevalence? How much lost work time is health generating in the workforce? What's the associated lost productivity? And finally, how engaged are employees in their own health and health management? So what we assert are these 10 dimensions of population health that can be measured initially with a single metric. Now again, think of that idea of a dashboard. So we go through the 10 dimensions and we say there's a single metric to start with. So for example, in the financial arena, program costs per employee. In program participation, the percent of employees that are participating relative to all employees in the organization, etc. So there are ways that we can come up with an initial metric to reflect the status of that dimension as a starting point. And I think what we like to emphasize to employers is for each of these dimensions, in each metric, work with your partners, your supplier partners, to get a benchmark that you can use to start to see how do I compare. Because as you'll hear later on in this presentation, employers will often focus on the metrics that are really problematic and drill down and focus on those. So it's a way to, at a very high level, identify where you're doing well, where you're doing okay and where you have real problems. So this is a structure and a strategy for beginning very complex data sets together in a very straightforward way. And the other way to think about these 10 dimensions is a set of leading indicators of health, a set of indicators that focus on treatment, and a set of lagging indicators of health. Now, for the most part, what employers have done historically is focused on the single lagging indicator of cost. And in trying to manage cost, what employers have done is change their plan designs, shift cost to employees, etc. So employers have put themselves in the unenviable position of trying to manage cost on the back end without ever paying attention to the leading indicators of health and the treatment indicators. So by organizing these metrics in this way, employers can start to see on the leading indicator side, where are my problems? Do I have more health risks in my population than other employers? What do my biometrics look like? What about chronic conditions? These are the things that will lead to treatment and lagging indicators. So it lets the employer start to look broadly but pretty simply at these three components of health and start to really focus on where I am today, and as I intervene with new programs, what changes over time. Now, finally, in this setup, one other thing about metrics. Now, as I said, we're starting with 10 dimensions of health and a single metric in each, and we call those dashboard metrics. But, of course, we all know those high-level metrics are made up of more detail. And so we like to think of metrics as hierarchies of information. So beneath the dashboard metric, there are component metrics. There are individual metrics that make up that higher level metric, and beneath that, there are contributing metrics. And we lay this out in this way because when an employer sees a problem area, then of course what the employer wants to do is drill down and understand the drivers of that issue so the employer can take action. And so thinking about metrics in this structure of hierarchies allows, on the one hand, a very pragmatic, straightforward approach, but allows the employer and their partners to drill down into the detail and become very sophisticated about drivers so they can help take action. So I wanted to lay that out for you because that was the framework we used in the research we published of the case studies. And we'll have Donna and John talk about some of the details of the employers that we worked with in this research. So Donna, take it away.
Thank you, Tom. As we get started, I'd like to give you a little bit of background and experience on O'Neill Steel. Founded in 1921, O'Neill's the largest family-owned group of metal service centers in the U.S. Our corporate office is located in Birmingham, Alabama, and our chairman of the board is Kraft O'Neill, third-generation leadership within the organization. Some of our challenges come in the next description of our company in that we actually, under the O'Neill Steel umbrella, have 10 different companies with 90 locations encompassing 3,000 U.S. employees. This year marks the second year of LIVESMART, O'Neill's signature health and wellness program. A little bit about the background of O'Neill's wellness program. We've dabbled in health and wellness initiatives for years. We started out several years ago with annual on-site health fairs, the biometric screenings, and our results were delivered in aggregate reporting. Generally, we found the same type of health care risks, just in a different order of prevalence depending on the area of the country and the screening site. We moved those health fairs in the second and third year to a more aggressive approach with vascular screening. That was beneficial as well. However, again, we were very limited on the outcomes, on the reporting that we actually received, and we really didn't know if we were making an impact. We partnered with a vendor for a 3-year weight loss program with a focus on cash incentives for employee and team approach. However, there was very little value added, very few opportunities for coaching to identify what was really going on within our various groups of employees. To continue what was wrong with the picture, we offered one-time events. There was no follow-up or coaching. There was really a lack of accountability. There was no outreach as far as for employees to set goals. Very limited return on investment to share with our corporate leadership as well. And granted, with 10 different companies, 90 different locations, we were spending a significant amount of money on these screening events. Some of the things, though, that we were doing right was offering wellness and preventive care benefits at no cost to our employees and their covered dependents since 2008. We also offered health plan options at either no premium or a lesser premium for those employees that were more aware of their health needs and, again, could benefit from a lower cost program. We have offered on-site flu shot clinics and voucher programs for our employees and dependents for many years as well. After about 6 months of planning and working with an independent consultant, we decided that we needed a program that could sustain time. We worked with our independent consultant to make a presentation to our leadership team as to a program that would offer strategy, metrics, goals, and would sustain the course of time. As you'll see in this screen, Holman Head is our president of O'Neill's. He was actually the first employee screened. He set goals with his personal health coach, communicated these goals, and committed his ongoing support to the program through various modes of communication. As I mentioned earlier, we were looking for a program that provided a strategy, metrics, and goals, a program that we could measure the results over time. In our first year, we were working on the engagement of our employees and the participant satisfaction. Engagement, I believe, actually is the measurement of success with your programs, trying to get those employees involved. Participation is the bare numbers. What percentage did we get as far as our population goes to participate? The engagement was really trying to put a measurement on those that were willing and ready to make changes in their day-to-day lifestyles. When we moved into our second year of the program, we started measuring behavioral changes. We were primarily looking for increase in exercise rates and, of course, being a southern-based company, the decrease in the tobacco use was a factor that was very important as well. Clinical improvements such as mentioned earlier, the reduction in risk factors. Our employees, we know today as well as a year ago, need to continue working on those goals associated with increased exercising and, again, decreasing tobacco use as well. As we move and look forward into years 3 to 5, we are going to start measuring our health cost trends. We will actually be integrating some other areas as well, and at this point in time, we're working to find the right database or data warehouse management tool where we can bring all of the areas needed to identify our success with our program and make that presentation to our management group as well. The key metrics of our program, as I mentioned earlier, is definitely our screening results, the results of our health assessments and engagement. Our demographic data is definitely a big factor. Some of our locations have anywhere between 2 to 200 employees, so definitely making sure that we're reaching out at least once a year with on-site health coaching and biometric screening is very important within our organization. We are integrating our health and pharmacy, disability, safety, and absenteeism data. We're in the very preliminary stages of that, and we continue to evaluate our programs, both with health audits, coordinator surveys, and actually trying to measure continued employee engagement and satisfactions with the programs that are offered to employees and their spouses at this time. The next screen outlines our current participation in club status as for 2012. As I mentioned, we have O'Neill has 10 companies. The company names are listed on the left-hand side, along with the next column that identifies the number of employees. This screenshot actually measures 2011 and 2012 participation, both existing from 2011 that also participated in 2012, as well as new employees. Overall, we saw an increase across the board, and I will talk about some of the incentives in the ongoing communication of programs that we feel helped drive our participation in 2012. Looking at our measurement strategy, in the first, as I mentioned, in the first year, looking at the first part of the leading indicators was our program participation. We continued or immediately followed up and continued to measure employee satisfaction and experience. Beginning with our second year of LIVESMART, we also invited spouses to participate since we understood a high dollar amount of our claims experience is related to our spouses and other dependent members as well. Our measurement strategy includes looking at key indicators, again measuring, continuing to measure on a frequent basis employee engagement. The lagging indicators include our health care costs, our absenteeism, and employee retention. And as I mentioned, we are looking for the right database management tool to take all of these demographics, biometrics, measurements of lost time, lost productivity, and start putting these pieces together in a meaningful report that we can evaluate and again produce and offer programs to our employees and their families to meet their needs. The next screen outlines our LIVESMART Go Platinum participation. Each employee and spouse goes through a biometric screening on an annual basis and personal health coaching with an outreach to a health coach no less than 2 to 3 times a year. Employees and their spouses are actually placed in a category, bronze being the lowest, moving up to silver, gold, and ideally platinum. This screen also evaluates employees who were screened in 2011 and rescreened in 2012. The screen actually reads from right to left. In 2011, you'll see that 2% of our population was in the bronze category. In 2012, that participation level dropped to 0.5%. Next was the platinum with about 36% in 2011. That dropped to 23.5% for 2012. And as we look at the gold level, participation and scoring actually increased from 56 to 61%, and platinum, or our top level, increased from 6 to 14%. So we have seen and are able to demonstrate measurable improvement in outcomes from 2011 to 2012 based on the club status. Moving individuals to a healthier status results, of course, in the reduction of risk and avoidance of poor health issues. The health status that we were looking at in 2011 included blood pressure, BMI, blood glucose, LDL, the use of tobacco, the number of days a week in employee exercises, and ideally working toward that goal of platinum club status. Based on 2011 results, goals were set for 2012. This slide actually depicts 2011 goals based on 2012, and in the last column, the status column, you'll see either a red, gold, or green circle. That denotes whether we are on target with those goals or whether we need to be looking to develop and offer programs and support those programs to help our employees, especially with the red and the gold circles, dots. Those are actually the levels where we can where we need to offer the greatest improvement and the greatest impact in the upcoming year. So our next step was to offer each of our companies a scorecard. We continue to communicate with our companies the health status. 1 through 7, as depicted on the previous slide, restates where we stood with each company at the end of 2012. Definitely some areas for improvement are noted based on the goal that was set, and we continue to, as I mentioned, to develop programs to help reinforce continued health initiatives within our companies. Certain companies that we find, and I think is very interesting here, are, I don't want to call it more profitable, but generally in those companies where we see more green and gold circles are actually our more productive, our more engaged employees that generally have greater outcomes and are more profitable groups as well. We're going to talk about our benefits and incentives in our LIVESMART Wellness Program. Our incentives are based on club status, both for the employee and their spouse. The bronze level pays out at $50 a year for each employee and spouse, moving on up to a goal of $300 in cash a year. To piggyback that, we also offer our employees a premium reduction for participating in LIVESMART. The employee and spouse that participate will receive a 12.5% monthly reduction in their health plan premiums and an additional 12.5% if the employee and all family members are tobacco-free. This year, or in 2012, we offered a high-deductible health plan. We are starting to look at the metrics involved with enrollment in the high-deductible plan as it relates to our wellness program, just to see if those that are in the high-deductible necessarily carry less risk factors. So far, we have not seen that, but again, we will continue to incent our high deductible health plan, keep our LIVESMART Wellness incentives in alignment with what our actual goals are in the programs as well. As far as additional programs, we offer recreational and fitness reimbursements up to $400 a calendar year. For employees who participate in wellness activities, we are also offering Weight Watchers online and in locations that meet minimum participation levels. O'Neill believes that it's essential to weave health and well-being in the culture of our organization. As I demonstrated earlier, the presidents of our company are engaged in the screening process. Employee communications from our C-suite, including our chairman, and each company's president is actually rolled out to employees on no less than a quarterly basis. Our presidents set goals, they communicate their goals, and they also communicate their successes or where there's still areas for improvement. We try to give meaningful recognition to both our employees and our locations who participate in wellness programs. And as mentioned earlier with our high deductible health plan, we are trying and working to integrate health into our benefit plan design in our workplace environment. At this time, our programs are not perfect, but again, we are working with our employees. We continue that evaluation. Our C-suite, our executives are highly engaged in the successes of our program as well.
Thank you very much, Donna. It was a great overview of what O'Neill has been doing in programs, in tracking. And I'd like to turn over to John Riddell now, who will talk about the other two case studies in the research. So, John, take it over.
Thanks, Tom. When Tom asked me if I'd be interested in collaborating on this case study, it didn't take me long to say yes, absolutely. I've been in the wellness and disease management field for a long, long time, and the population health management field as well, and I think that's kind of the new term that we use today. And we did these kind of things, the things that Donna's talked about, because they made intuitive sense. But I think now the change is we have to show what works and how well it works in order to help companies, and especially the C-suite, see these strategies not as a cost of doing business necessarily, but as a competitive advantage. And I think these three are really great examples of that. You've heard from Donna, and I'm going to talk a little bit about American Express and Barrett Industries. But this next slide just gives you a little background on each of the case studies that we incorporated. And I'll wait for that shift to occur. There we go. We were looking for companies that spanned a wide range of sizes. Barrett Industries has 725 employees. O'Neill Industries, something over 3,000, 3,000 in the U.S. And American Express is the really large employer with 60,000 employees. And we wanted companies that were aware of the importance of a broad range of metrics, but not necessarily having perfected their data management yet. Now, clearly, American Express is out front, been doing this for a while, and I'm going to talk a little more about some of the interesting things that they've done. As Don has mentioned, O'Neill was moving in the population health management direction and needed good metrics to help craft appropriate strategy. Barrett Outdoor Living was really only starting to look at the cost of poor health. They connected with HC21, a business and health coalition, and that made a significant difference for them. I'll share a little bit about what I mean by that. So the next slide is what prompted each employer to adopt a broad population health strategy. So when I interviewed each of the companies, I spent a fair amount of time on this. They first mentioned that without understanding the importance of knowing the full cost of health, you really wouldn't employ the assets needed to do this. It isn't inexpensive. And senior management really needs to understand the business value of a healthy workforce. If you don't have that, you really kind of need to be putting energy into it. Donna has many times indicated that the chairman and the presidents of the various companies were on board. That's really pretty critical. How do you get them on board if you don't already? Well, the case study I think is useful, and there's growing evidence of the business value. And I would also say, I was just reviewing the latest Towers-Watson report on reshaping healthcare, the 2013 report, and I found it interesting. In their concluding remarks, their first bullet was use data and metrics to understand the cost drivers of your health plans, vendor efficiency, and population risk profile. So it's become pretty clear how important this is. Metrics are essential to this understanding. I would say that without these 10 essential metrics, how do you know the business value within your own company? I don't think you can. And finally, it's not simple yet. Each company is working with a data manager, an external data manager, and I know that Donna's group is researching and trying to figure out who is the right data manager for them. So those were the four things that kept coming up over and over as I talked with these folks about what prompted them to move forward. How is the data being used? Just to kind of give you a structure for this, there are 5 areas that appeared to kind of emerge as the areas that were being used. So, and I'm going to share some examples of this. Strategic planning, Donna talked about that a fair amount. Program planning, program evaluation, pretty important. Cost-benefit analysis, and vendor assessment. And I would say with regard to cost-benefit analysis, you know, a lot of folks talk about return on investment, ROI. And I would say, and I think Tom would agree with me, this is a really challenging metric. It requires a stringent methodology to pull it off properly. And we would recommend that if you can do that, that's great. But you might want to look at a different option, something we call return on value. That's a concept that makes sense, and it's more easily applied. So going to American Express to provide you a little backdrop in terms of how they use their metrics. I think most people know American Express is a large financial services company. They're a Fortune 100 company, and they're in the credit card and charge card business. They're also very call center and customer service oriented. And they went to Dr. Burton, who had a lot of experience at Bank One and at Chase Bank, organizations that use call centers extensively. They wanted him to take population health management at American Express to a high level. And so, of course, one of the advantages there is that Wayne was able to kind of name some regulations that would be required if he was going to take the job, and one of those was he wanted to make sure all vendors provided their data in kind of an integrated way. So I'm going to talk about these 3 areas, strategic planning, program planning and program evaluation. And I think that American Burton have done some very interesting things. And keep in mind that this isn't a presentation on what we found in the sense of we want to share with you what they learned, but how they use their metrics and why it was important to them, because every company has a different need with regard to the metrics that they use. So I also do want to mention with regard to customer service and that's the program planning piece here, is really kind of the big kahuna at American Express. They know that high levels of customer service, when you get on the phone, you're talking to somebody at American Express, if they provide you a high level of customer service, it helps to keep you as a customer. And happy customers tend to tell their friends about the experience. And the effect they've found is really almost geometric, so that the business value of population health management is that it improves health, and you'll see the data are clear that healthier employers have better customer service scores. So that is one of these unique kind of correlations that is business by business centric. And in this case, if there is only one piece of data, I think that Dr. Burton were to pull together and share with senior management, customer service scores and the connection to health is that. So what metrics are they capturing? Well, all 10 of them that Dr. Perry and Bruce Sherman are suggesting, all 10 of them. What was interesting is when we started the case study and started interviewing Dr. Burton, they weren't doing employee engagement yet. That was a piece that they didn't have. But shortly after we started, they decided on 3 items that they would include in their health surveys, their health risk appraisal, in order to begin to gauge employee engagement. So they use all 10. I think this is an interesting example of the way that they use data. This is their ethnic hotspot graphing. I'm seeing more and more of this kind of data display. I saw some of it with the work that Donna was doing, but what it tends to show is areas of need. So in this graph, down the left-hand side, you see the various health issues and risks, and he doesn't name the companies, but they're highlighted as W, X, Y, and Z, and you can begin to see and kind of use this as an early warning system. Where are the issues? Well, in this case, you can see that there is life dissatisfaction at company Y is at 2.5. That's a high number. It's in red. So it quickly kind of points out where the issues are. And as Tom has said before, that this then provides the opportunity to look at that and start to drill down into the data components you have to try and figure out, well, what's happening and maybe why that's happening, and to begin to make some program changes and ultimately be able to track change over time. And I know that Dr. Burton uses this kind of information as just kind of on a basic metrics correlations on a daily basis. The next one, the next slide, I think is really an interesting slide, because this is where he tracks health status and customer satisfaction. And you can see here that those people who are manning the phones, especially, who are at low risk, have much higher, they have higher customer satisfaction scores. And those who are at high risk have lower customer satisfaction scores. Now, this is 2 percentage points different, which may not seem like a lot, but they've really got this down to a science. They're able to translate these percentages into the significance of retaining and attracting new customers. And I think it also shows, and this is something that I think Tom mentioned early on, we're beginning to looking at healthcare programs as just a cost of doing business to a growth view, to a revenue-producing view, and this really starts to get at this. This is such a critical piece for American Express. But they're also looking at other areas that are really important. Dr. Burton's done a lot of work around wellness, disease management, and the impact on medical costs, but also on some of the productivity loss issues. So this is an example of a small graph that kind of tells a big story. That number of risks is a huge factor with regard to disability. Here, someone with 4 or more risks is likely to have almost 5 times the number of disability days per year. And that becomes an issue because companies are paying people for that time off, plus you're not getting any productivity while they're not at the work site. So this is a real key area. And the next slide just kind of takes the concept a little further. The research is clear, and the work that Dr. Burton has done is pretty clear that as the number of risks increase, so does the amount of productivity loss measured, in this case, as presenteeism. And this kind of information can be segmented by age, gender, ethnic background, and such in order to help focus effort. And I know that he developed, and this goes back a few years now, but he developed a calculation for determining how much you would actually save if you were able to reduce risk for a particular group from 4, say, down to 2, or from 3 risks down to 1 risk. And that's been, I think, a really useful tool for him as well. And so let me shift quickly to Barrett Industries. It's kind of a favorite of mine. I wrote an article a year ago for the International Foundation of Employee Benefit Plans on how small employers can create data-driven health management strategies. And one of the things I found is that one of the biggest problems, of course, is that being fully insured, which Barrett is, means that you're at the mercy of your health plans. You're buying a benefit from the health plan. You're not self-insured. Problem is you typically can't get your own data from your health plan that you're buying the insurance benefit from. And so what Barrett did is they tied into HC21, Healthcare 21, a local business and health coalition, and that was powerful for them because, and I'll tell you in the next slide why that's the case. These are the key metrics that they're capturing there. So you can see that these pretty much are along the lines of what Dr. Perry and Dr. Sherman outlined in their article. They did not have a data warehouse. So by joining HC21, HC21 does have, they actually created their own data warehouse, the only coalition that has. So they got access to that. And then the other thing is because any health plan member that wants, any health plan that wants to join HC21 has to commit to providing detailed client data. So really, Barrett, it was a really significant decision to hook up with HC21. And then the next slide shows, I think, and one of the reasons this is one of my favorite case studies is because they've remained fully insured, and they've seen premium increases over the last years, pretty much like everybody else, into double digits. But now they're seeing a reduction in those premiums to single digits. In fact, their renewal rate in 2013 was 3.6% compared to a trend of 12% or higher for other companies. And typically the trend for fully insured versus self-insured companies is much higher. But this is the lowest rate that the broker of Barrett had ever seen. And there were a variety of reasons for that, but I think the powerful thing here is they were able to actually get that data from their health plan. So they could start comparing and doing the kind of benchmarking that Tom was talking about before. And now they have the potential to move towards self-insured. They're thinking about doing that. They haven't made a final decision on that. I think, I do want to say one other thing about Barrett. They were also able to, because their health plan incorporated a wellness component into the benefit, Barrett said, that doesn't quite fit for what we're trying to accomplish. They were able to get the plan to give them those dollars, which is fairly significant, I believe somewhere around $40,000, $50,000. It's a small company, of course, to use as they wanted to use and to target where they wanted to target it. So I think a pretty successful situation there. The last two slides are some of the observations that we've made with regard to the case study. Initially, I put audience to sleep with a very long list of observations, and I thought, ought to be able to whittle that down to those that we think were most important. And so I've cut it down to 8, 4 in each of these two slides. So first thing is targeting. I was saying, O'Neill and AC21 have found, and Donna did not talk about it, but that individual referral at kind of point of contact is much more powerful than an announcement about a general program. And they're able to do that. So if a person has certain risk profiles, they're able to actually give a person a referral to coaching or some other program. Experimenting with your own correlations is pretty critical. I think starting with a dashboard, as Tom has suggested, with 10 metrics is very important. And as you go beyond that, it really becomes company specific, and you have to really look at your own correlations that make a difference for you. We found that cost benefit, is really important. Everybody wants to know, are the programs making a difference? And it's valuable, but it's not the only driver for senior management. We found that in all cases, they're interested in knowing that employees are living healthier lives. In fact, I think one of the words that's creeping into our industry lately is the term happiness. We want happy people. And I think data warehouses are pretty essential, at least for now. And if you've seen one data warehouse, you've seen one data warehouser. Cost is a huge factor. You have to be careful. I was talking with Tom the other day, who indicated he had a wonderful project, a very important project, and because they had to use an external data warehouser who had the data, the cost of getting that data precluded the ability to move forward in the project. But I do think that data warehouses are critical. And 4 additional observations. I would say, first of all, I'm working on a project now with a large organization, and we have aggregate reports, which are certainly helpful, but we are really finding we've got to get to the individual data level. It makes a huge difference in terms of programming and evaluation. Not easy to get, and we're trying to get this from several different health plans, but I think it's really the direction the field is going. Wayne has a wonderful situation. He has access to all data sources. Often those are distributed around an organization, and you may have this problem. He likes to say in his presentation, is this a problem for any of you? And almost to a person, it is a problem. And so if there's a way to modify the reporting structure, that can be really helpful. The silo issue is problematic. Tom mentioned at the beginning one of the key issues is that's a dead end. Well, it is. And I think we're getting better at it. We're always getting better at it. And I think everyone knows this has to be addressed. It is not always easy to do. And then I would say my final observation is that these 10 essential metrics are important to a whole variety of groups. We all know this. I'm not telling you anything very new here, but I would add to these groups those in the C-suite, program planners and administrators, program evaluators, people in benefits and HR, workers' comp, folks doing the disability work are all important. But we sometimes forget that oftentimes we make it or break it based on frontline supervisors. If they can't see how a healthier employee who's taking some time away from work is going to help them get more product or more quality product out the door, how do you get their buy-in? And you really have to have it. So, Tom, those are my comments, and I'll shoot it back to you.
Thank you very much, John, and thank you very much, Donna. Here's our speaker contact information. Let me make this a couple of observations. When we came up with this framework in the basic metrics, we understood that there's a business case that has to be made if employers want to integrate their data. And we would, of course, argue that integrating data at the person level is really important. And I think this is really shown by the work that Wayne Burton has done, because what Wayne has done is he has been able to look empirically and analytically at the question of if we improve health risks, how does that impact things like healthcare costs and lost time and performance and customer service scores? So the fact that Wayne has integrated data at the person level allows him to look at those impacts from those kinds of interventions. So I think starting, if you're an employer that has data in separate places, starting with that basic framework of the individualized metrics is key to gaining that big picture. But eventually, as you look at things, you'll want to go to that notion of how do I see what's affecting what, which really means you have to integrate data at the person level. So here's our contact information if you want to follow up with any questions. If you'd like copies of the paper on the pragmatic population health metrics that we mentioned early on, the actual research of the 3 case studies, or the presentation, you can email me. There's my email address. If you'd like to find out more from Donna about what she's doing or what John's doing, that's their information as well. So I want to thank you for your attention today. Again, I want to thank Donna and John for your participation. Thank you all very much.